My title I was given is sensitivity of time, getting it right in clinical practice, and I am time sensitive at the moment to make sure that we get to lunchtime, because I've got that important slot. So when we look at time sensitivity, I was looking at, what does that mean? What does that mean kind of in life in general? And what does that mean clinically? So we look at the definitions, and it immediately throws up words regarding an urgency, doesn't it? Urgency of action, immediate attention. There's words on there saying that we've got an insufficient amount of time. Desperate, emergency, grave, burning, life and death even. So what does that conjure up, in us as clinicians? I think we've all probably felt a little bit like this within a working day at times. Because the busier that we are, the more panicked we become. So then we start to waste time, and wasted time equals wasted potential. And then that in turn can be a wasted effort of the time that we've put in, a wasted pursuit. We don't need telling, do we, that there isn't enough time in a working day, just in life in general. Lists become longer. Those of you who have, I used to be a district nurse before Tissue Viability, and I presume there's a lot of people of you here who work in the community, and you get your daily visit lists, and, some days you think, how on earth am I going to get through that? And so patient care, unfortunately, becomes a task to get through. So how do we best manage that? So what is time sensitive in healthcare? So we associate this often with emergency care. And that's correct, isn't it? That's how it should be. We've all heard and read and probably witnessed ambulances stacked up outside of A&E in hospitals, especially during the winter. Winter's coming upon us, except for Gary, because he's going back to sunny Australia where the summer is on them. But yes, we get we're not hitting admission targets. So they are time sensitive, certainly. So where does wound care fit in? Now, if we look at a non-essential definition, the words can be delayed, no undue risk, low or no time-sensitive procedures, would they result in permanent harm to the patient if they were deferred? We could argue that, yes, they would, because they would have a longer-term harm. And, this happens, doesn't it? If you have, so those of you who do work in the community, sometimes you'll get call outs, won't you? So if I give you a scenario of you have a call out of somebody with a block catheter, you have somebody with a syringe driver, that's alarming for a patient with palliative needs, or the bandages have leaked through. In that priority order, where's the priority of the leg bandaging or the dressing that's had the strike through? It will come at the bottom, won't it? In reality, that's where it will come. So it's weighing up the priorities in risk. But then down the line, a person who, is being delayed, or we'll move that, we'll move that visit along the line during the week, or we can only come once a week. And they've got their lymphedema, and, we're not putting the compression in place, then down the line, that person is going to get potential, they will have long-term effects and various symptoms associated with that. So where do we put time sensitivity within wound care? We know the current challenges in practice at the moment, don't we? And again, looking at community services, about 60%, maybe more in some areas of care delivery is for wound management. And time allocation for a visit, 15 to 30 minutes. Am I kind of right at the moment with that? Yeah, in some areas that is what's happening. And if you were doing, a full new lower limb assessment in a clinic, the clinics I've worked in, we used to have about 90 minutes for one new assessment. And people laugh now and say, 90 minutes? My goodness, we haven't got that much time. We also have a decline in district nursing, and we've got a ratio of 1 district nursing per population of 14,000 people. There's a decline in student nurse applications across the UK, and a reduction in those specialist contacts, tissue viability nurses such as myself. There's reduced time allocation, as I've said, and then those healthcare logistic delays. If you're writing prescriptions still, or if you have supply chain, just your products for the patient, delays, so we get delay in treatment. So, the time sensitivity can be an issue there. So we have to remember to breathe. We have to jump off the wheel at times. I had a manager who always used to say to me, get off the wheel. And I'm like, oh, well, in theory, that because you're running like this, aren't you? And it's on my list and I've got to do this and I've got an insulin at 12 and, and all these things going on. But sometimes we have to just get off that wheel. We have to stop. We have to breathe. We have to have a look around and say, what can we do differently? So when dealing with time-sensitive issue, it's important to approach it in a systematic and an efficient manner. So this is coming from project management terminology. Claire, you'll be familiar with this. But as nurses, we're masters at the systematic approach because that's what we do in nursing, isn't it? So we must identify the deadline and the time constraints that we've got to work with. What is the issue and when should that issue be resolved? We have to prioritise. What happens if we don't do X, Y and Z? What if we don't have that Doppler today, to perform that? What if we've got a delay in getting the compression, for example? What is going to happen there? We have to break down what needs doing. So break down the tasks into manageable steps. And we do that within our care planning. That's why we put in, we can have standardised plans of care, but then also make them individualised to your particular patient. And that will help us to stay on track. We use, algorithms, we use pathways, all these things that are put in place to just give us that step-by-step guidance. We must communicate, so important, obviously, so then we can support each other. We can delegate tasks. So that's looking at our interprofessional, our MDT, multidisciplinary team working, because we can't do everything just on our own. We have to monitor the progress and adjust things. So that's evaluating and reassessing as part of our nursing process. We have to avoid rushing and don't compromise the quality of what we're doing. It's not just we're going in to see that patient, or a patient is coming into clinic, or we're seeing a patient on a ward and we're just going to change the dressing. What was done last time, there's a dressing there in the box and we'll put that on. We have to think about what we're doing. Re-evaluation and escalation if things change. So escalating that to your senior members of staff, somebody who is a more knowledgeable other within your team if that's the case, and again the MDT. And careful planning and communication. So we have to adapt and be diligent in what we are delivering. So stay focused and disciplined. And we can create deadlines. You might think, well, does that apply? But it all does apply into nursing practice. And follow the evidence. We've got a lot of evidence out there. We've got the National Wound Care Strategy Programme in England. We've got lots of best practice documents, consensus documents. I read last night the new one, they might have it on the Journal of Wound Care stand, the international consensus document about venous and arteriovenous leg ulcers, really interesting. So there's things coming and being developed all the time. And the National Wound Care Programme, they had the tranche sites where they had lower limb clinics being introduced in areas where they weren't already, and they've just evaluated that evidence, and they can, we can see from where that's been done, healing rates, 52% of leg ulcers healed within up to 12 weeks. Recurrence rates were low, cost effectiveness has gone up, and also environmental impact, because without the kind of cars being driven, the reduced of visits, net zero, and everything like that. I've done a lot of audit work in places where I've worked myself in, because I've been lucky enough to have lower limb clinics and services, and to be able to put pressure ulcer teams into place, for example, banging that drum, as Claire said, collecting the data to identify and raise that issue. So on a daily clinical level, how can we utilise our time to make a difference to patients' wound care? So even in wounds that are complex and regarded as non-healing. So I want you to meet Steve. And this is a story of how, and I love a patient story. I mean, that to me, that it does speak, and also to use those patient stories alongside, your numbers, your figures in data. Trust boards can't ignore that, and they, if you do it well, I've got a lot from delivering the patient's voice to the trust boards, for example. So Steve is a 65-year-old male. He's originally from South Africa. He was in the South African Army. Like he described himself, he's a big man, is Steve, very tall, big tough guy. And he's got a history of hypertension, atrial fibrillation. He's got, which he takes medication for, chronic venous insufficiency. He's got varicose veins, ankle flare, the usual types of hemosiderin staining, and his ABPIs were 0.89. So we're kind of on a normal trajectory there. So Steve had a leg ulcer on his shin, on his left leg, that was there for 17 months when I came into contact with him. And what he did was, he's a joiner by background, and he was doing some work in the area where he lives, and he dropped a box out of his van, and it just clonked him on the leg. It's the typical, isn't it? Just skincare wound that wouldn't heal. And so the treatment initially was, just self-treating, got the Germaline out, as you do, the little elastoplast and things. And then it looked like this. This was so July 2023, two sort of fairly small, skin tear wound to the leg. It didn't heal, and it sort of started growing. And he did go to the GP and said, I've got this. What's happening? And so in his GP practice, they didn't have particular lower limb services. They had what we call like a basic dressing clinic, what the practice nurse would run. In the area where he lived, in the NHS Trust, there are no lower limb clinics. There's certainly not any leg clubs there. And he was classed as non-housebound. So it was kind of this backwards and forwards, go to your GP, but the services are not there. So he ended up just trying to manage it himself. When I saw him, this is the wound at this point. So that was in December 2023, so Christmas just gone. And he had as you can see there, I don't know if the redness shows up in truly enough there, but he had a raging, spreading infection. It was all spongy around that wound in the tissue, lots of exudate, malodor, and pain. Like I said at the beginning, big tough guy, Steve, but he said, I can't cope with the pain. He couldn't sleep at night. He didn't know what to do, what do I dress it with. He was given kind of small pads and tape and things like that, from the GP, and I think his wife was going to murder him, because you know how it is, if you're, as much sympathy as we have for our other halves, if you're trying to sleep at night and somebody's there getting up and down and moaning and groaning, you just want to go, for goodness sake, don't you know? So and it causes problems, in relationships and things. So lots of complications were going on for Steve. So initially, what did I do? So there's a timeline and a journey here through him to healing. So remember, end of December, just literally before Christmas. So on my initial visit, I did. I discussed with him. I educated him. I talked to him about, the issue. Because people say, well, why isn't it healing? Can we leave it to dry out in the air? Or, it's that understanding, isn't it, of that etiology. And like, Gary says, it's that, using those, one thing I love fruit. What is it about fruit and wounds that we, equate? Apples to ulcers, that's my thing. Got one for the pot there, Becky. But he's, he was really concerned about it. So we did some curettage, some sharp debridement initially, to get rid of some of that slough away. And I taught him how to use a monofilament pad so he could then cleanse his own wound, because I wasn't going to be there all the time. The services, he didn't have any services access around him. And, he's a capable guy. So I was like, right, we're the team and your wife, and we're going to do this together. So I taught him how to do that. Initial stages, we had an antimicrobial dressing in place and then another absorbent dressing over the top. Doppler's done, assessment, everything else, suitable for compression. So we got him a hosiery kit. So that was 2 weeks down the line before we got that hosiery kit to him. So this is the journey then he goes on, as you can see. So we go on and on and on and on. So he himself is cleansing, he's doing wound bed preparation, he's applying the dressings, he is applying the hosiery kit, he's putting a barrier cream round the edge of the wound when there was a lot of exudate, he's putting emollient on his leg, and February 29th, 10 weeks later, that is how the wound is. So at this point, we are nearly healed. He, in this time, is sending me photographs and he's giving me updates on what's going on. And he's so proud of himself, he's really motivated into this. He's completely part of this journey. And then at March 23rd, 13 weeks later, he's healed. He's fully healed at this point. And there he is in September. Do you know what I said when he sent me that picture? He said, I'll send you one of it, because now and again he calls me the doc. And I can't do a South African accent, but it sounds really funny when he says it. And but he sends me updates on how he's doing. And I said, Steve, where's that maintenance hosiery? You knew I was going to say that, didn't you? Where is it? I can't put that on the screen. But yeah, no, I am doc. I am wearing it. He says. So he remains healed. So the point of the story is what can we do as clinicians to better manage the time available to care? So it's about having the time for that robust wound assessment and that what we call basics of care. Because if we don't do those initial things, if we don't do that initial assessment and then we put in those care plans and things into place, then we're going to lose time down the line. And if somebody like Steve, we can get them into a self-care journey, admittedly, everybody can't go on that journey, but we can, some people can. We're going to save a lot of time. We're going to save, economically, we're going to save, because clinician time is the most expensive thing in that wound care circle. We need to put the dressing into context. What is that dressing going to do? What do you want it to do? In the exhibition, there's lots of wondrous things there, but do think about and reevaluate what you are using and why. that wound bed preparation, as I mentioned, you know, if you haven't got sharp debridement skills, there are lots of courses for you to go on to be able to do these things. And curettage is so simple. Or, you know, autolytic debridement, the monofilament pads, for example. Just whatever you want to call it, wound hygiene, wound cleansing, you know, and support our new staff to do these things. There's something in, when I did my medical education certificate, and we call it the zone of proximal development. You take people on this journey through, and then we have this scaffolding around them, and then we can kind of remove it once people become confident. A bit like learning to drive in a way, I suppose. So we have these more knowledgeable others, you know, the more people who might be more senior in the team. It's really important. There are so many student nurses who are coming straight into community practice now. So I did that many years ago, and I was told you can't do it. You can do it, you know, it's a different role, isn't it? Every department or wherever you go is to work in nursing is a different role. But if you come straight into community and then you're off doing visits and things, and you've got wounds and you haven't even done an hour of wound care on your university 3-year course, you know, then my goodness me, you know, how are we going to manage? So we need to support each other. We need to have things like our well-led clubs, you know, and the you know, politically it's been talked about utilising social groups and models, you know, the community sector, voluntary sector. Did anybody hear Keir Starmer's speech last week about the you know, the changes to the NHS? And he talked about we have to have neighbourhood health. And I thought, well, Ellie's been doing that for years. Ellie, I think you need to get on the phone to Parliament and have a word. She's on it, yeah. You need to tell him how to be going on, because, you know, we know these things, don't we? But that's, you know, we get a new 10-year plan in place and we get different objectives. And that's good and it's great, but they need to be backing that up and supporting us. So we have to create that culture of quality and excellence. We have to bring people along with us on that journey. So also there'll be some people who are in senior leadership roles here, I understand as well, and you know, what can they do for wound care practice? There's Ellie and I when we were in Parliament, and Ellie has raised, you know, the issue of inadequate resources for lower limb care, and that was last year an event there. So our senior leaders, like within our ICBs, have to acknowledge these issues and look at service commissioning. There are emerging independent providers in collaboration with the NHS, and I do some work with one of those, and that's good. It's good that we have this available. We have to recognise the benefits of collaborating with our industry partners as well, because they will support us with good education and wanting to get good patient outcomes, so that, you know, they'll help us put pathways and things into place. We have to break down barriers between multi-professional teams. We still work in silos often, you know, podiatry are there, dermatology are there, and, you know, tissue viability. We have to, vascular and everything else, we have to break those barriers down. We have to embrace new technologies, don't we? You know, we've mobile phones, you know, that's how I worked with Steve. It was brilliant. But there are these great apps available that will measure a wound and tell us how much, you know, what is the tissue type and things. So you know, that again, that was one of the things talked about in changes with the NHS, is that across the board patient record system. I might have retired by the time that all comes to pass. We have to ring fence education, because it's essential to practice. And during COVID, unfortunately, we lost a lot of that. You know, things were put on the back burner. There just isn't time. And it kind of carried on down the line, didn't it? You know, well, we haven't got, you know, there's nobody available, we haven't got time. Or you get a course booked, you know, I might be delivering a course for, you know, lower limb, so, you know, and then it's, oh, well, half the people haven't turned up because they've been pulled back onto the shop floor because, you know, we haven't time to release people. But if we don't get that education in place, how do people know what they're doing? And we're putting ourselves at great risk there by, you know, sending people out unprepared, without competencies. And we have to look at how we do that. There are ways and means of doing competency assessment, OSCEs, things like that. You know, it's not just a tick box exercise. So we have to be revisiting all those things. We have to raise the issues and key messages in the public arena, just like Ellie does, and be accountable for harm-free care. There are some people who believe that lack of lower limb care is as much of a risk and should be reported as are pressure ulcers as a patient safety risk too. Social media is great. I was talking to Gary before about this, and we were saying how, you know, it can reach people. I know it can have its downsides to it, but 5 years ago I created this group, which is on Facebook. It's called Lower Limb Clinicians Together. Is anybody a member here? Oh, we have some members, but by the end of today, I want you to all be members. And the other two admins, Carol, my good friends Carol Young and Jenny McDonald, will be messaging me tonight going, have you been somewhere today? Because we've got a flurry of members. You just answer the questions that it asks you, just very brief questions, just to say you're real, you're a clinician, you know, no industry, sorry for the people from industry. But it's great. And we've got just short of 3. So if you all join, we might actually reach 3,000 mark. I can't offer a prize for the person who is number 3,000, but, you know, we'll maybe think of something. And we've got some people from across the board in there. We've got people from podiatry, which is fabulous. People like Martin Fox, who's a very senior podiatrist in the UK, and he's so active, giving advice, support, education. But I had a quick look through the other day, and the most frequently asked question is, what do you think it is? Concordance is a big one, actually, about, what do we do about concordance? But the biggest one is, is that on there? What dressing do we use? The biggest one, I've got this patient, I've got this, what dressing shall I put on? And then occasionally I'll put a post in and say, can we please just let's just stop a minute. Before we're going in the box to go, we'll have that and we'll have that, you know, let's just think about what is going on here first. There are so many tissue types, aren't they? So it's like, you know, how do we manage them? You know, just think about what we're doing with that. What are the, you know, yes, goals to healing, kickstart healing, but also the patient's goals will be very different to our goals. You know, the patient may want to malodor managed, you know, and they may want exudate managed. They maybe want to, you know, just feel less pain like Steve at night, get a good night's sleep. So this is time sensitive to us in managing a patient's symptoms and, you know, moving them along that healing trajectory, no matter what the wound is. There's a fungating wound on there. And of course, a malignant wound is not necessarily going to go on to healing, is it? But there are a lot of aims and goals within that for that patient and their family. We all know the Times wound assessment framework. I'm sure it's been talked about and mentioned through the conference. And, you know, it's really good I always say to people, when you go, every contact you have with a patient, every wound contact, you know, not just take the dressing off, put another one on, go through Times in your mind and look at that wound. And put then those basics, wound hygiene or wound cleansing or that wound bed preparation at every single wound contact, because, you know, we're not talking about biofilms and things, but we know now there's more evidence of proliferation, and these things will just grow and grow and grow. They're not just going to, you know, or we'll go once a week and then it's fine. You know, we need to get on top of things, otherwise we're going to end up with problems. Now, what I did with the Times is I was doing a lot of work with a condition called hidradenitis suppurativa, which is a dermatological condition which crosses the boundary of dermatology, but also into wound care as well, because wounds are created through this follicular skin condition. And so I've expanded the time for that. But then I was thinking about, and anybody wants to reference this, you've got to reference me, because it's about to be published but hasn't been yet. So this is hot off the press just for you. So I expanded on that, but it will work across all wound types really. And it sort of fits with today's practice. So the T, as we know, for tissue, gaming the optimal environment. The I is for managing infection, inflammation, and prevention of that too. The M is for that moisture balance that Gary was talking about, the Goldilocks syndrome, got that in the pocket, yeah. The E is for the edge of wound protection. And I've added then less at the end of time. So the L is for that location, because in HS it's important of where the location is, because these wounds can be very difficult to dress and manage, like in the groin, in the armpit, round the buttocks. But that's lots of wounds, isn't it? The location, and then what is the cause then of that wound? Sherlock Holmes hat on, looking at what, you know, the root cause is. If we take something away or we put something in place, that also is going to go towards healing. The E is for education not only to the patients, like I did with Steve, but also making sure we are educated and our staff in our teams are as well. The S is to support patients and staff, so that MDT working, you know, the support groups like the Lindsay Leg Club is that social support for patients. And then the final S is for self-care. And we've talked about that a lot because that came a thing through COVID as well, isn't it? But there's been, you know, if we do that right and we do that well, it can have, you know, those good impacts. And I said it can save a lot of clinician time by doing that, but do follow the right path. So time is of the essence in wound care. We know we've had those burden of wound reports. We know where we are, don't we? The prediction of that is a worsening situation. I think we're up to about £10 billion in wound care or something like that now. You know, when Julian Guest produces his report, it kind of keeps building and building and building. And that can then send us into that panic situation. But we are here now. Now is where we are. So let's act right now, whether it's just your basics of wound care on your daily visits or on that bigger scale, and the things like what Claire was talking about, putting your quality improvement in place. We don't have a TARDIS, do we? It'd be great, wouldn't it? Can't go backwards and forwards. So we just have to deal with the here and now. And just a final thought from me. This is a really good book if anybody's read it or to get hold of, and it's called 4,000 Weeks, and it's about time management for people, for mortals. And 4,000 weeks, if you're lucky enough to live to the age of 80, you will get around 4,000 weeks in life. When you put it into that context, not much, doesn't sound much, does it? Doesn't sound much at all. And time officially speeds up as you get older and riper, without a doubt. So that's a fact. So do use your time well, and but also be kind to yourselves and kind to each other as well. Thank you very much.